All right, let's dive in. Today, we're basically cracking open a secret language, the language of medicine. We're going to take a look inside what's called the coder's playbook, specifically for the musculoskeletal system, to figure out how something as huge and complicated as a surgery gets boiled down to just a simple, universal code. I mean, we've all been there, right? You look at a medical bill, you see this string of numbers, and it just feels completely random. How in the world do they get there? How does the physical act of what a surgeon does in the operating room get translated into this universal language for billing and records? Well, it turns out it's not random at all. There's this highly organized system behind it, a kind of coder's playbook, and it's all built on a foundation of rules, decision trees, and, incredible anatomical precision that turns every single procedure into a reproducible code. And just like any good playbook, before we can start running the complex plays, we have to master the fundamentals. So let's talk about the building blocks, anatomy, and the simple rules of the game. So step one is just knowing the field of play. The body is divided into two main parts: the axial skeleton, that's your core, right? Your skull and ribs, and then the appendicular skeleton, which is all your limbs. And coders have all these little tricks, like simple mnemonics, BBL for bone-to-bone ligament, that become their best friend. Now, what's really cool is how simple the logic can be sometimes. For a wound, a coder just asks one fundamental question: does the repair require a deeper surgical exploration? If the answer is yes, boom, you're routed to one whole set of codes. If it's no, you go to a completely different set. It's just a clean, decisive split. And get this, it's not always about the action, it's about the target. For trigger point injections, a doctor could do, say, 10 different injections, but if they're all in only 2 muscles, it's coded as just one procedure. The key isn't the number of pokes, it's the number of muscles treated. That's the golden rule here. And this is a perfect example of how the logic starts to get more layered. For something like draining a joint, a coder uses a matrix. They need to know 2 things. First, the size of the joint. Are we talking a small finger joint or a major joint like the hip? And second, did the doctor use ultrasound to guide them? The intersection of that row and column, that's what gives them the right code. Okay, so now let's see how all these building blocks start to come together. We're going to escalate from those simple rules to one of the most complex areas in all of medical coding, the spine. The playbook handles this incredible complexity with a really elegant metaphor: the spinal hierarchy stack. See, you don't just use one code for a massive back surgery, no way. Instead, you literally build the code, layer by layer, just like the surgeon builds the repair inside the patient's body. So this stack has 4 main layers. You start at the very bottom with decompression, which is basically clearing out the problem area. Then on top of that, you add arthrodesis, which is the fusion of the joints. On top of that, you might add instrumentation. We're talking rods and plates. And finally, the very top layer is the bone graft to help the whole thing heal. Every single one of those layers is its own add-on code. And inside that stack, oh man, the details are everything. Is the surgeon working on the vertebral segments, the bones themselves, or the interspaces, those gaps in between? Did they approach from the front, what they call anteriorly, or from the back, posteriorly? Each one of those answers sends you down a completely different path of codes. And if you zoom in even closer, you'll see that even a single layer, like that bone graft we mentioned, has its own complex little playbook. A coder has to follow this whole decision tree just to figure out the right code. Was the bone from the patient or a donor? Was it taken from the same incision? Each path leads to a unique final code. It's incredibly detailed. Okay, that was pretty complex. Let's take all of that logic and apply it to something we can all picture a little more easily: a broken bone. This is where the playbook really meets a real-world scenario. So before any treatment code even gets chosen, the fracture itself has to be understood. The coder is basically an investigator, asking questions based on the diagnosis. Was it a traumatic injury? Is the bone knocked out of alignment or displaced? And where exactly on the bone did it break? Top, middle, or bottom? Once they classify the injury, the treatment code isn't just one single choice. It follows a very clear path of clinical escalation. You can almost think of it like a staircase of care, where each step represents a more intensive level of intervention, starting with the simplest fix and going all the way to the most complex. So level 1 is the most straightforward. The bone is in a pretty good position, so the doctor just provides support, like a splint or a cast, to let it heal on its own. No manual resetting or anything like that is needed. But if that bone is displaced, we've got to go up to level 2. This is what you probably picture when you think of setting a bone. The doctor has to actively manipulate it, physically push it back into its original position, and then they apply the cast. And for the most severe cases, you have level 3, open treatment. This is full-on surgery. The site is opened up and the bone is repaired directly, often with internal hardware, like plates and screws to hold everything together while it heals. So we've gone from simple rules to complex stacks, all the way to real-world scenarios. And now, we're going to turn the tables. It is your turn to think like a coder. You've seen the building blocks. You get the if-then logic. You know why it's so important to count the right thing, and you see how these complex procedures are stacked together. You now have the core principles of the playbook. So take a look at this list. You've got an ORIF, that stands for Open Reduction Internal Fixation, of a patella fracture. You've got an arthroscopy of the shoulder. These are real diagnostic challenges, and using the logic of escalation and stacking we've just talked about, every single one maps to a specific answer in the playbook. You've just gotten a peek behind the curtain into this incredibly systematic, logical world of medical coding. It's not magic, it's a playbook. So now the only question left is, after seeing how the system works, what do you think the codes are?